Okay, now we're going to talk about ketamine. Ketamine is a high risk medication, and it's a high risk medication because there's a high risk for a medication administration error. Because we give ketamine for a lot of different things. We give it for pain intranasally, intramuscularly, intravenously. We give it for agitated delirium, and we give very large doses for that, both intravenously and intramuscularly. We give it for post intubation management. We give it for induction for RSI or DSI. So there are a lot of different doses. So I'm going to talk about a particular way to give IV ketamine for pain to avoid giving too much. We did have a case in our department where they gave the IV dissociation dose when they intended to give the pain dose. All right. Fortunately, there were no adverse events that resulted from that, but it was a medication administration error. So when we're giving IV ketamine for pain, only use the 1 cc syringe. You will not need to use a larger syringe if you are drawing it up to put it in an IV bag, so a 100 cc bag, to give over 10 minutes. All right, you will not need to use a bigger syringe because the max IV dose is 35 milligrams. Now, if I am giving 35 milligrams, the most that I'm going to want to draw up, so it's 0.25 milligrams per kilogram with a max of 35 milligrams. I'm only going to need to draw up 0.7 mLs. And now with the IV form, you don't need to be particularly concerned with dead space. So you can draw up the exact dose. All right. If you're using a 1 cc syringe, then even if you draw up too much, you're going to be giving not a whole lot more than the max dose. All right, so you'd be given at most 50 milligrams instead of, say, it's a 100 kilogram patient. You're not going to be able to give 100 milligrams. You're not going to be able to give the dissociation dose if you use a 1 cc syringe. All right, you will get into the recreational dose range of 0.5 milligrams per kilogram, and you're likely going to see some psychoperceptual effects. All right, now if it's a kid and you're using a 1 cc syringe, well then yes, you can give the dissociative dose. Okay. And when I think of ketamine, I'm thinking if we're giving an IV dose for pain and I'm giving more than 30 milligrams, all right, I need to rethink and make sure I'm giving the right dose. Okay. If I'm giving 100 milligrams if I'm giving 100 milligrams IV of ketamine to any patient, I'm thinking this is probably too much, and we miscalculated our dose somewhere. So the general rule of thumb, around 25-30 milligrams of ketamine so that we don't give too much. But if I'm given 50, 75, 100 IV for pain, that's your litmus test that tells you you're giving too much IV ketamine for pain. Okay, I know that was a lot, but we have a little bit more left to go. All right, now there is an alternative option now to give IV ketamine, very slow push. and I'm going to give you my recommended strategy for that. It is using to make the math simple, using a 10 cc syringe and pulling up 0.5 mLs. 0.5 mLs. All right. Your max initial dose is 35 milligrams. Okay. So if I'm pulling up 0.5 mLs, then I'm pulling up 25 milligrams. All right. 25 milligrams, which your 25 milligrams should cover the vast majority of patients, since it is 0.25 milligrams per kilogram. Because if I'm given a 100 kilogram patient 0.25 milligrams per kilogram, that is 25 milligrams. Okay, so if I pull up a half an ml in 9.5 cc's, all right, then I have 25 milligrams 25 milligrams of ketamine in 10 mLs. And if we divide that up, we'll see that it is 2.5 milligrams per ml. 2.5 milligrams per ml, because it is 2.5, 5, 7.5, 10, 12.5 to 15, 17.5, 20, 22.5, 25. So 2.5 milligrams per ml. So if I'm given a 100 kilogram patient 25 milligrams over 10 minutes, and I give roughly 1 cc per minute, when I'm given that, I can just sit there and tap it in. I'm not doing firm taps. I'm doing it just enough to barely make the plunger move, and I'm watching the time to make sure roughly that at the 5-minute mark I am about halfway through. Now it seems like a lot, and the protocol does say over 5 to 10 minutes. However, if I can go longer with IV ketamine, I want to. Now you might be thinking it'd probably just be a little simpler to give it via piggyback and hang it IV, and that's true. That's true. Setting up IV piggyback isn't especially easy either. So I'm going to play a video about setting up.
Okay. Hi everyone, welcome to a demonstration of how to prime an IV piggyback line by back priming, or back flushing we call it. This is just a clip of how to do the back priming. For the full skill, refer to our other video, IV piggyback demonstration. So since we're just doing this small part of the skill, for this purpose, we'll say that we've already done all of our rights, all of our checks. We've assessed the IV site, checked in with the patient, checked in with our order, our MAR. All of that stuff is done, and all that stuff is detailed in the other video. It's also important to note that when you're doing this in the clinical setting, make sure you check your facility policy, because different facilities have policies about how to prime an IV line. So I've gathered my supplies. I have my primary tubing, my IV bag, some alcohol swabs and gloves because we're handling medication. My primary line is set up, and I know that my primary is compatible with my secondary. So I'm in the patient's room, checks are done, I've explained the procedure to her. I'm gonna wash my hands and put on gloves. I've already identified her, done my checks, explained why she's getting the med, all that good stuff that we always do with any time we give meds. All right, so I'm gonna go ahead and open up my tubing, and I'm gonna clamp it first. You always clamp your tubing first so you don't lose any of your med when you spike your bag. I'm going to take my med that I've already labeled and checked. I'm gonna take off the cap here. I'm gonna take off this cap, being careful not to contaminate either of these ports. And I'm gonna push and twist until my tubing is in my bag. I know I'm clamped, so I can turn this the other way, and I'm gonna hang it on my pole, squeeze my drip chamber so it's about half full. And then I'm going to attach my tubing to the secondary port here, making sure it's the port above the pump, because remember the medicine has to go through the pump. And I'm gonna go ahead and swab my port here for about 10 to 15 seconds. And I'm gonna let it dry. And then I'm just going to plug in my tubing here, making sure not to contaminate either of these pieces. Okay, so this tubing is full of air right now because I haven't primed it yet. So I'm going to back prime it. I've plugged it in. I'm going to undo my clamp, and then I'm going to put this secondary bag lower than my primary, and you can see how the primary bag is going into this tubing for me, and it's pushed all of the air into this bag. So now I have a fully primed line. Then I'm going to make sure to lower my primary bag, because the primary bag always goes lower than the secondary. I'm going to undo my clamp here because I want this medication to run in. I'll program my pump and then finish.
Okay, I thought that might be a useful demonstration of piggyback and back priming. Now, back priming will not work with some IV tubing if the medication, or if the piggyback, the secondary infusion, if the IV tubing has a one-way valve. So if you don't have the specialized tubing for a piggyback infusion and it has a one-way valve, then it's not going to work because you won't be able to back prime. But it does illustrate how a piggyback is set up. Now, I can do IV piggyback with or without an IV pump. So if I wanted to give IV ketamine, and if I thought, a barrier to me giving it over an IV opioid was that I have to set the ketamine up on a pump, then I can hang it by IV piggyback via gravity. Okay, I would still make sure that my ketamine is placed higher than my primary, my main line, all right, so that my ketamine goes in preferentially because it's higher, therefore there's more gravity forcing it down through the line, up and back pressurizing the one-way valve, all right, keeping the medication from my main line, all right, that's going to flush the rest of it in from going down preferentially. So the ketamine would just be connected to the most proximal port, and then the ketamine bag would be higher. And then the reason that we would want to piggyback our ketamine in is because if we don't piggyback it in and we have it on a pump, then once that medication from the ketamine, once the medication has finished infusing, air is going to get into the line. But if it's piggybacked, then once the level of the medication in a line gets below the level of our main infusion, that's going to take over and it's going to flush it in. So you're not leaving any medication in that line. So there are a lot of different ways to give ketamine, and I want to provide all these different options so that we would use it when it's indicated. One of the reasons we're talking so much about ketamine is because it is a high-risk medication for having a medication administration error. Okay, and this has happened in EMS in the pre-hospital environment, and a patient has died as a result. And we're going to watch this case to see what happened here.
Okay, so she's not breathing anymore. Gave her too much ketamine. Danielle needs intubation equipment.
According to the lawsuit, following the lethal overdose, EMS workers weren't able to provide ventilation to Gwen for 7 to 9 minutes, depriving oxygen from her brain.
It was actually then the failure to do the most basic thing, which is secure her airway and bag her with oxygen. that ultimately proved to be the most direct fatal cause of her death.
I do believe in all my heart they were trying to help.
Though a lawsuit won't bring her daughter back, Heather Myers hopes it leads to more training and improved safety protocols for first responders. She believes Gwen would have wanted the truth to come out.
We want to just ensure that no other family has to endure this.
One thing I want to point out, that exclusive clip that we showed you of first responders on scene, it was blurred because that first responder was not the person who injected donor with that ketamine. So we want to make that very clear. In a statement to KSL.com, a spokesperson at Intermountain Health says that at this time, due to pending litigation and federal laws that protect sensitive patient health information, we're unable to address the details of the situation or respond to specific questions. We can say, however, that we're always committed to providing the safest, highest quality of care possible for all.
So, one would think that given too much ketamine, we give that dose routinely, all right, we give a dissociative dose routinely to patients who are agitated. We're going to be giving it for induction. We're going to be giving it for post-intubation management. We already give it for post-intubation management. So what was the problem with giving that dose? It wasn't necessarily that they gave a quote lethal dose. It's lethal if there is not appropriate monitoring and aggressive management after that. Because as you should be well aware now, ketamine in a dissociative dose can cause apnea, can cause respiratory depression, can cause hypotension. So for those reasons, because there is an increased risk of giving too much ketamine, because we give it in all these various forms, my recommendation is that you routinely monitor waveform capnography for any patient that you're giving an opioid or ketamine to for pain or for anything else. All right, it should be the standard. And it's not that I think you wouldn't be able to recognize the signs and symptoms of respiratory depression without it. It's that if we consider the Swiss cheese model of medication administration errors, anytime the holes in the Swiss cheese all line up, these mistakes can happen to anyone. So if we get into the habit and the routine of monitoring waveform capnography anytime we give any narcotic agent, we're likely going to recognize respiratory depression sooner, even hypotension sooner, apnea sooner, and we're more likely to respond more quickly and aggressively when we do recognize that. So for those reasons, I do recommend that you monitor waveform capnography anytime you give a narcotic. So to reiterate, some multimodal approach recommendation: consider the patient's preference, consider how severe the pain is, all right? Consider the type of pain. So for example, patients with renal colic should probably receive NSAIDs, all right? It's more than pharmacoanalgesics. It's more than just giving a medication. You have options, all right? The patient has options for the management of their pain. Even physical touch is comforting. Use repositioning, breathing techniques, all right? Have them slow their breathing in through the nose, out through the mouth. Splinting, good solid splinting, taking the time to apply an appropriate splint could reduce how many medications you have to give. Code therapy, guided imagery, having them think of their happy place. If you've seen Happy Gilmore, think of their favorite place to be. For kids, using toys, blowing bubbles, music, pacifiers, having their caregiver present can also be part of that multimodal approach, and those should be documented accordingly. Now, if you want a ladder of when to give what, generally I recommend you start low and escalate up. Now, there might be patients where as soon as you make contact with them, you know that their destination is going to be an opioid. So maybe you work your way down from the most aggressive, all right? And we give fentanyl or we give ketamine, and then we give either Toradol, Tylenol, or maybe if they can take oral medications, we give oral Tylenol, NSAIDs. But either way, you need to consider this multimodal approach to pain management. And here's another reason, is because even if we give IV opioids, it takes a long time for that patient to get pain management in the ER. And it is helpful giving an opioid for that reason if we're giving it as we're pulling into the ER doors. But the half-life of that opioid is still pretty short, all right? So if we really want that patient to have a longer duration of reprieve of the management of that pain, then we should be giving non-opioid medication. All right, and remember, our goal is not 0. A clinically relevant pain reduction is considered a decrease in 2 points on the scale. Okay, so in summary, pain management or the management of symptoms is complex. It requires a multimodal strategy that provides a more targeted approach. It can result in decreased opioid utilization, less side effects, and a longer duration of action. All right, but because we are giving more medication, there's an increased risk in medication administration errors. Remember, think deliberately, verbalize what you're doing out loud. I'm going to give this dose. Perform a medication administration cross-check. If you're not doing that for every medication, start doing it now. Get into the habit of performing a medication administration cross-check. As always, I hope that this was helpful. Let me know if y'all have any questions, and thank you.